Thank you very much.
Well, thank you for the kind invitation, and thanks for the association for inviting me to come over here. So the subject of the talk is technical considerations and results of lung transplantation for pulmonary hypertension. And those are the three subjects I divided it up into. So first, talk about preoperative considerations. There has been a very good and thorough classification, which I won't go into detail, but it's mainly either primary or secondary pulmonary hypertension. Like the New York Heart Class Association, there are 4 classes depending on the patient's symptoms. And there have been major advances in the targets of emerging therapies in the last 10 years or so. And there are different pathways, obviously the endothelin pathway, the nitric oxide pathway, and the prostacyclin pathway, where the different drugs act on. And the conservative treatment, I will not go into detail, obviously, but they are probably best summarized in the 2015 European Society of Cardiology or Respiratory Society guidelines. The one thing I wanted to mention that oral anticoagulation is recommended as part of the treatment, and that's why these patients, in addition to their vasodilatory drugs, they have an increased risk of postoperative bleeding. Now, there's also in the guidelines is also clearly described, where's the place for lung transplantation, and it's obviously you start with single treatment, combination treatment, and if there's still treatment failure, then patients will be considered for lung transplantation. Now, if patients decompensate on the waiting list, which does happen in those patients, a lot of patients actually, ECMO is used as a bridge to transplantation. There have been several reports on also awake ECMO therapy, which can be utilized in these patients. And when you use ECMO, it's always important to look what kind of ECMO. If you have no cardiac decompensation, veno-venous might be sufficient, or veno-arterial or veno-arterial-venous. As a technical feature, there's a very nice new cannula out on the market now for veno-venous ECMO, which can be used, the so-called Avalon cannula, which can be used in these patients. Now, what happened after the lung allocation score? We heard a little bit about heart allocation before. In lung allocation, we have a score, as most of you will know, which is from 0 to 100, depending on diagnosis and risk, death, or mortality on the one hand, and potential of survival after lung transplantation on the other hand. Now, what has happened with pulmonary hypertension since the introduction of the lung allocation score? We know that high-risk diseases such as idiopathic pulmonary fibrosis have benefited a lot from the LAS score, but how about pulmonary hypertension? And there's been this publication showing that actually on the one hand, as you can see in the last 2 lines, more patients with pulmonary hypertension were transplanted after the introduction of the LAS score, and fewer patients died on the waiting list with the diagnosis of pulmonary hypertension. So that's obviously a very good sign. The survival definitely is not worse of patients with pulmonary hypertension after the introduction of the LAS score. It's even a little bit superior. Still, it's on the other hand, it's obviously a minor percentage of all the diagnoses which we see in our lung transplant population. It's about, I would say, as a solitary indication, it's about 5% of all the patients we do. And if you look at heart lung transplantation, which is the other treatment option next to double lung, we see that the numbers did go down, obviously, over the last years of combined heart lung transplantation, but primary or secondary pulmonary hypertension, such as in Eisenmenger syndrome, still represent the main indication for a heart lung. As you can see on this slide, congenital heart disease and basically primary pulmonary hypertension consider more than 50% of all patients still being referred for heart lung transplantation. Now, some words to intra and perioperative techniques. Some of it I can go over pretty well. We all know that the surgical techniques is either usually done double lung transplant through 2 mini thoracotomies or through a thoracosternotomy clamshell incision. rarely median sternotomy is used mainly for heart-lung, combined heart-lung transplantation. We have these two options, which the main option now is obviously double lung transplantation, and a rare option is combined heart-lung transplantation. Now, with regard to the technique, it's a standard technique for lung transplantation, which I will not go into detail, but very often you do have a pulmonary artery size mismatch, which is important to look at, and you might consider using pericardial patch or something like that for a patchplasty to achieve a good pulmonary artery anastomosis. Now, we have a limited donor pool, as it has been mentioned before, and we have marginal donors in a lot of brain death persons, so reconditioning by reperfusion is an important goal, and there are two methods of ex vivo lung perfusion. There's also the OCS system, which you have seen for the heart before, which can be used during the transport already, and led by the Toronto group, we have the ex vivo perfusion system, and the experience is actually very good with those systems, as it has been published and just mentioned in the talk before, that the results of EVLP are very favorable. And you can do a lot of things in the future, maybe with perfusion drugs, inhaled agents, or gene or cell therapy, which might even more advance the use of EVLP. What's very important to mention that obviously it's essential in pulmonary hypertension to use intraoperative ECMO, and ECMO is much more frequently now used than conventional cardiopulmonary bypass in patients with pulmonary hypertension. And if you look at this publication, you see that as an a priori indication pulmonary hypertension, ECMO is used in all of the cases in this large program. And if you look at the survival rates, there's no difference whether you use ECMO, that's now all indications, also fibrosis and other indications. There's no difference, a significant difference in survival after transplantation, whether you use ECMO or you don't use ECMO. And this has also been published with extended intraoperative ECMO, which means you use the ECMO intraoperatively, but then you use peripheral cannulation, you close the chest, and you transfer the patient to the ICU on ECMO, which is very important for patients with pulmonary hypertension, that the new lungs are not flushed with a high pulmonary artery pressure. You might get along with nitric oxide, but very often this does not work. And therefore, it's highly recommended to use extended intraoperative ECMO therapy, transfer the patient onto the ICU on the running ECMO, and you see there's no survival disadvantage if you do that. It is a challenging anesthesiologic management, so it's certainly not an easy pump case where the patient, as you see here, the anesthetist sits there, drinks coffee, and reads the newest journal. But it's actually very challenging, and you need extremely experienced anesthetists in the room to manage those patients. Probably of all pulmonary indications, that's the one you want to have the best anesthetist in the room. Also very important is the use of catecholamines, and very often these patients have post-cardiosurgical vasoplegia resulting in malperfusion and lactic acidosis. So that's very important to look at. So your lung might be fine, but then you have a problem with your heart after the transplant. Now, a few last words to postoperative therapy and results. We have increasing, if not stable, numbers of bilateral lung transplantation, fortunately. So that's definitely still a treatment option. If you look at the survival, though, it's still the case, and it's always been the case, that results with pulmonary hypertension are inferior to other indications, which is mainly due to primary graft failure here at the beginning, that you lose a lot of patients within the first 10 days, and then the survival is obviously comparable. Those are the different pulmonary hypertension classes, primary or secondary. There's not a real major difference if you look at the different subtypes of pulmonary hypertension. What are the main causes of death? Is in the first 30 days definitely graft failure. There's no doubt about that. Then infection, of course, very often these patients, are on the ICU long time. Sepsis and so forth might be a problem, and then then in the long term, obviously, obliterative bronchiolitis is a problem. Heart-lung is very rarely performed these days, particularly for primary pulmonary hypertension. It's basically not performed anymore at all, and we have just a little bit above 50 heart transplants in the registry at the moment. Although the results are pretty good, they're definitely comparable to the results of double lung transplants for pulmonary hypertension. So there's no difference there. And here are the difference indications for heart-lung transplantation listed in this slide. The long-term outcome, however, if you surpass the first period, which is a bit more dangerous as in other indications, the long-term results are actually pretty good with regard to transplant, and these are the different transplant types, and single lung is definitely inferior, so single lung transplantation is basically not recommended anymore for patients with pulmonary hypertension. And you see that you also, if you look at the right ventricular diameters and functional parameters of the right ventricle, you see, like we see for the correction of congenital heart defects, we see a nice recovery of the right ventricle in these patients with pulmonary hypertension. The long-term, basically the immunosuppression, there's not much difference basically which primary immunosuppression you use in those patients. It's mainly, of course, either tacrolimus or cyclosporine in combination with mainly MMF these days. Those is the percentage of patients suffering from an acute rejection. It's usually about 10%, 20%, maybe less than that. And the main long-term complication, as in any other lung transplant population, is obliterative bronchiolitis. So let me summarize. Lung transplantation is an established therapy for end-stage pulmonary hypertension. Despite the increase of transplants, percentage of patients with pulmonary hypertension has not increased due to improved medical therapy. Double lung transplantation with intra and postoperative ECMO support is the procedure of choice. Intra and postoperative management of pulmonary lung transplant patients remains challenging. Lung transplant as a treatment option is in many countries limited due to donor organ supply. EVLP and DCD donors might increase donor pool, as we just heard about. Heart lung transplantation is performed very rarely and should be limited to patients with complex Eisenmenger syndrome or end-stage heart and lung failure. Thank you very much.
That was a great talk. Any questions from the audience? Okay, well, I have one. What should we be doing for patients preoperatively? You have somebody on your donor list. Is there anything that we can do to optimize them to help improve that intraoperative and postoperative course?
Yeah, that's a very good question. And as due to time reasons, didn't go much into detail, but there is, of course, I mean, all the drugs which you use for the treatment of pulmonary hypertension are the worst drugs you can imagine for anesthesiologic management of these patients. And therefore, it's not really, I mean, the best drug is still nitric oxide, but nitric oxide, of course, is not used in patients which are ambulatory or on the regular floor. And whether it's prostacyclin or particularly the combined treatment regimen, the patients are just prone to postoperative vasoplegia plus bleeding complications. So but you have just to face reality. On the other hand, the treatment is so good that the patient can be managed medically much longer than they used to, so you can't really take those drugs away. So the only answer is, proper intraoperative management and have the best team available for perioperative management. That's my only answer I have.
So I guess we'll continue to suffer with bleeding and vasoplegia.
Exactly. The surgeons will continue to suffer.
Okay. Oh, yeah.
This is okay. It's work. My question to you and for the table here is that sometimes I struggle is when you finish the case. Okay, you're on VA ECMO. I just did a case like yesterday. The patient was 3 weeks on VA ECMO, primary pulmonary hypertension. You do a double lung. The patient is completely stable at the end of the procedure. Okay, you turn the flows to 1 liter. PA pressure is good. Lung function is good. So at that point, how do you make a decision? Do you leave the patient on VA ECMO? And if you do leave, is there a number of days because you don't have a lot of criteria to make your decision when to decannulate here, because the patient is already stable. You want to use as a more a prophylactic strategy, right?
Yeah, yeah.
So what is your...
Well, if I would talk to the American College of Cardiology, I would be very sophisticated of telling, what drugs we use and what parameters we like. Simple surgical answer, keep them on ECMO. In pulmonary hypertension patients, I would be very reluctant to switch off ECMO intraoperatively, particularly if they have been on ECMO before.
Yeah.
Another 3 or 4 days will not make a difference. But if you turn it off and you have a problem 2 or 3 hours later, then you're in deep trouble.
Yes, yeah. So I would agree with that, and I think that also affects the way that you decide to cannulate the patient, especially when they're a bridge, because I would anticipate leaving that patient on for a couple of days. Yeah.
That's great.
Thank you very much. All right. Our next speaker.